Hi everybody, this is going to be a overview of diabetes mellitus. So what is diabetes? It is a chronic condition, and we have two issues going on. We have hyperglycemia and also the inappropriate of metabolism of carbohydrates, fats, and proteins. We have two types and two different reasons. Remember, type 1, you have absolute absence of insulin. In our type 2s, you have a resistance to insulin with a decreased insulin production. So in type 2 diabetes, again, insulin secretion decreases, cells become resistant to insulin. There is a synergistic effect where as insulin secretion decreases, it leads to an increase in insulin resistance, or as insulin resistance increases, it can lead to a decrease in insulin secretion. So just some comparisons between type 1 and type 2. Again, type 1 typically is autoimmune. There is an absolute lack of insulin. There is a strong hereditary link. There is an abrupt onset, and peak is usually between 12 and 13 years of age. I did go into some examples where there are some exceptions to the norm. Type 2, insulin resistance or an insulin deficiency, which you can tell is completely different than having an absolute lack of insulin. A decrease in the number and size of pancreatic beta cells, insidious onset, so again this is gradual. There is some genetic predisposition, so there is some similarities here, but you can see there is difference in age. But again, as I mentioned, unfortunately, more individuals are being diagnosed at an earlier age with type 2 diabetes. So when you look at the clinical manifestations between type 1 and type 2, you'll see some similarities. You see the hyperglycemia. What's most common in type 1 are the 3 Ps, polydipsia, polyuria, and polyphagia. Obesity, so there's a little bit of opposites here, is usually something that makes a person more predisposed to type 2. Polydipsia, remember, polydipsia is going to the result of hyperglycemia. Skin infections, again, bacteria love sugar. Blurred vision, I talked about that a little bit in class. That is a result of the excess glucose will basically cause an irritation to the inside lenses to swell in the eyes that will lead to blurred vision. Fatigue is similar in both, and also nausea and vomiting and some stomach aches are common in both as well. This slide here goes over more just of the natural negative feedback loops that the body goes through when we have high blood glucose levels versus low glucose levels. So this is just a good model to look at in terms of knowing what the body does when serum levels get high versus when glucose serum levels get low. So if you need to take a few minutes to review this slide. So when the body lacks insulin, and let's use our type 1s as an example for this. So if there are no insulin, there's no way for glucose to get into the cells, because cells need glucose to do their functions depending on what that cell is. So that can lead to polyphagia, which basically is a message to the body to say, hey, you really need to eat something, because the body is trying to survive. Now also what happens is hyperglycemia, because if there's no insulin, you're going to have an elevation of glucose circulating in the bloodstream, which will trigger the body's response to try to lower that amount through osmotic diuresis. So the body is going to get a message to get rid of that excess glucose in the bloodstream. So ways it's going to do that is there's going to be an increase in urination, which will lead to glucose in the bloodstream. But all that diuresis also leads to dehydration. So in the same respect, body will send us a signal to say, hey, why don't you go and drink some fluids? So this just kind of gives you an overview of what happens when there is not insulin or enough insulin in the body to manage the amount of glucose that is circulating in the bloodstream. So when it comes to diagnosing diabetes mellitus, these are going to be reviewing the test to make a confirmation of the diagnosis. So you need to know these levels, random plasma glucose levels of 200 or greater. Also must have the signs and symptoms of diabetes, or a fasting plasma glucose of greater than 126. Patient needs to be NPO for at least 8 hours, and that means nothing to eat or drink. The 2-hour post-load glucose, this is going to be typically used for gestational diabetes and is not an indicator of type 1 or type 2 diabetes. Further testing, the glycated hemoglobin, the HbA1c or just A1c, gives an average blood glucose levels over approximately 2 to 3 months. This is basically where I talk about that patients really can't lie about their control because what happens is excess glucose or glucose will actually hitch a ride to red blood cell, and here's our beautiful red blood cell. Blood cell, red blood cell. And this right here is your glucose molecule. So if you know the average lifespan of a red blood cell is about 120 days, this looks at the average blood glucose level and how many of the percentage of red blood cells have glucose attached to them will give a good indication of control. So typically 4 to 6% is good control. Goal for diabetics is typically less than 7, but anything greater than 8% is an indication of poor diabetic control. So again, this is where diabetics really cannot lie. Urine testing is not a good indicator to diagnose diabetes. Testing is usually for ketones, is for are type 1 diabetics. It is a waste product of fat metabolism. It can also kind of be the precursor for ketoacidosis, and it is highly recommended for type 1s during acute illness and stress. Testing for renal function. Our kidneys really take a beating for both type 1s and type 2 diabetics. So what we'll be looking at is protein in the urine. A lot of patients just doing kind of like the point of care test isn't always a good indication that there is some involvement of the kidneys, but patients who are diabetics typically have to do what's called a 24-hour urine, and they actually have this big humongous jug where they pee in, and there is a test to look at how much protein is coming out in the urine within a 24-hour period. But if those numbers are high, there is a good indication that there is some involvement or damage to the kidneys as a result of poor control. So the chronic complications from diabetes, we have both macrovascular and microvascular changes. So let's see if Bill's story will work here. Alright, let's see if we can get Bill's story to pop up here. If we can't hear it, I might have the volume turned off. Here we go. And what's really sad is, as I mentioned, that a lot of patients, when they are diagnosed early on, a lot of the manifestations that are unchangeable or cannot be reversed have not happened yet. So it's very difficult for a person to get a diagnosis, and since sometimes to them they don't even feel bad at all, they're not taking the diagnosis seriously. And so a lot of times it isn't until they're having actual complications that cannot be rectified is when they may take notice to what's going on with them. So a lot of the chronic health problems are going to be related to vascular changes that can affect many of the organs of the body. So when we're talking about complications, you know, yes, the body does need glucose in order to survive, but in excess it can cause damage to both the basement membrane. It causes thickening and organ damage. It can impair the function of cells, and it can also cause chronic ischemia and tissue hypoxia. So macrovascular changes, remember, think of heart and brain. Atherosclerosis can extend to the blood vessels in the feet, coronary artery disease, cerebral vascular disease, and peripheral arterial disease. Etiology, you know, you're looking at increased platelet aggregation, lipid proteins, also fibrinogen. And another component that kind of plays in this is the metabolic syndrome that unfortunately occurs more frequently in type 2 diabetics, which can actually lead to even more risk for macrovascular complications. And there's a slide later on in the PowerPoint that kind of shows some of the different components of metabolic syndrome. So again, macrovascular disease is the leading cause of death in all patients with diabetes. So your microvascular complications, remember, think small. You're going to think of the eyes, nerves, and our kidneys. Neuropathy with the kidneys occur in 20 to 40% of all diabetic patients, is the leading cause of end-stage renal disease. Retinopathy is the leading cause of new onset of blindness, particularly in those between the ages of 20 and 74. Microvascular complications. Make sure you just kind of understand how this affects your patient. You're not really going to be tested to know the difference between sensory motor or autonomic, but it kind of shows you what those complications at that micro level can cause. Other sensory neuropathy manifestations, you can have severe restless leg pain that is worse at night. Or patients can have hyperesthesia, which is an increased sensitivity to stimuli. So my mother-in-law, for example, she's a type 2 diabetic. She has this problem. So where, say, some patients have peripheral neuropathy of their feet, where they have a decreased sensation, she actually has the opposite. Treatments can vary with some off-label uses of different medications. Diabetic neuropathy, just know over time that diabetes can cause damage to the kidneys. And depending on how severe somebody's diabetes is uncontrolled, it can directly relate to how quickly the kidneys are damaged. So when we're talking about taking care of our kidneys and protecting them, first line is going to be prevention. And like I talked about earlier with like the protein in the urine, as you can see in this slide here, it basically shows, say, a person who has a healthy kidney versus somebody who's diabetic, where as fluid is being filtered through the kidneys, proteins actually leak out and find its way into the urine. So chronic hyperglycemia can cause damage to the vasculature of the kidneys and cause hypertension in the vessels of the kidneys. And sometimes, I'm not sure if you've heard it yet while you're in school, the term renal hypertension. So high glucose levels can cause this hypertension in the vessels. So the hypertension in the vessels will ultimately cause damage. So the way to combat this is through prevention. And so that's through the use of ACE inhibitors. It lowers the glomerular filtration pressure, which slows the development of renal injury here. It can help delay the onset of neuropathy. And the big factor here is that it does not affect the blood sugar. Motor neuropathy, talked about if you have patients with hammer toe and claw toe. When we get into foot care, we kind of talked in class that we don't want our patients' feet to look like this because you don't want the overlap. You don't want, say, if those toes are sweaty, will cause trapped moisture there, can lead to skin breakdown, increased risk for infection. So if you have a patient like this, what you will need to do is to place cotton in between the toes to kind of help separate them, or you can use natural wool as well. The autonomic neuropathies we talked about, gastroparesis, neurogenic bladder, loss of cardiac reflexes, defective counterregulation of glucose, and hydrosis, that's the inability to sweat, and erectile dysfunction. So again, when somebody gets a diagnosis, they really don't understand all of the different issues that can come over time with mismanagement. Peripheral neuropathy, this is something you're going to deal with more often with patients. Unsteady gait, decreased sensation of light touch. Proprioception is kind of understanding where you are within your space. So if somebody's standing, it can kind of affect their balance, which kind of contributes to an unsteady gait. Inability to feel pain and temperature. So that's why understanding proper foot care is really important, especially for diabetics, and also for you to know for testing purposes, not just for this class, but also for NCLEX. All right, we're about halfway through. If you need to, go ahead and take a break. This would be a good time. If you want to take a second, just enjoy the comic. All right, so we're going to talk about acute complications of diabetes mellitus. So acute complications, basically a rapid onset. One, hyperglycemia. It doesn't just happen to diabetics, but it can also be a result of overuse of insulin or misuse of insulin, too little food, or excessive physical activity. And so one of the teaching topics that I mentioned is if you have somebody that has a routine exercise regimen, if they make any adjustments to that regimen, they have to be able to compensate for that. So if you have a diabetic doing the same regimen but decides to kind of double up on their exercise, it's important to do education that they may need to have an additional snack before they exercise, or they might lead themselves to a hypoglycemic state. So here I kind of talk about blood sugars less than 50 to 60, but you're also going to read anything below 70 can be hypoglycemia. So at least for testing purposes, if you see something below 70, just consider it to be hypoglycemic. Know your symptoms for hypoglycemia. Again, remember this is your body response of the cells basically saying that your blood sugar is low. So you'll have sweating, tremors, tachycardia, palpitations, anxiety, and hunger. Again, it's your body saying, hey, why don't you eat something? If it does become severe, somebody can have seizures and have loss of consciousness. So it can be a medical emergency if it is not treated quickly enough. And one point, I'll go back, that I didn't mention in class is your brain doesn't really store glucose. It can't make it, it can't store it for more than just a few minutes supply. So it is important for brain function to have that constant supply. So that's why it can become a medical emergency. Treatments for hypoglycemia, patient education, allow higher sugars in those that are prone to it, and frequent monitoring. So if you take somebody's blood sugar level, you're going to treat it. Give them 15 grams of a simple sugar or carb. That's going to be equal to 3 to 4 glucose tablets, 4 to 6 ounces of a fruit juice or soda, 6 to 10 hard candies, and 2 to 3 teaspoons of sugar or honey. Once you check it again here, repeat if blood sugar hasn't increased. Once it has, you want to provide a snack of carb and protein within 30 to 60 minutes. This just kind of helps keep the blood sugars up instead of having a dip again. Because really what that simple carb is doing is just getting the blood sugar up, but it doesn't actually help to sustain it. Someone who is unconscious or unable to swallow, you'll use glucagon. It is a hormone that is produced by the alpha cells. You don't need to know the measurements here, but it is given either sub-Q or IM. Or if a patient is hooked up to an IV, it can be 25 to 50 mLs of 50% dextrose in water via IV push at a rate of 10 mLs per minute. Again, you don't need to know this amount, but know that somebody who's unconscious can either get glucagon by sub-Q or IM, or 50% dextrose in water via IV push. Diabetic ketoacidosis, as I mentioned, there is a separate PowerPoint that I recorded that's 8 slides. I think it does a much better job in explaining everything about diabetes, diabetic ketoacidosis, but what this slide does break down for you, if you kind of want to have a better sense, is just remember with diabetic ketoacidosis, you're going to have ketones, you're going to have metabolic acidosis, you're going to have glucose levels over 250, pH less than 735, positive for ketones, which hence is the ketosis, and the metabolic acidosis. So I mentioned in class, see how this is underlined. Other things that are underlined here on this slide are symptoms that are related to the metabolic acidosis. The other symptoms here is more related to hyperglycemia and dehydration. So just to kind of understand the idea of why somebody becomes ketotic or acidosis is through cell starvation. So you have, say, a type 1 diabetic, because DKA does seem to happen with more type 1s, is that their insulin demands are not being met. So they have high levels of glucose circulating in the blood. So nothing is getting to the cells, and the cells are starving. So what ends up happening in respects is a couple of bad things, really. Is if the cells are starving, it's going to send a message to the liver, and the process of glucagon is released, and it actually increases the blood sugar, because the cells really don't know any better. They don't understand that there is glucose already circulating in the bloodstream. All they know is they're not getting any, so they'll send a message to the body saying, hey, we need more. Can also probably send a message of polyphagia saying, hey, eat something as well. But if this doesn't work, what it's next going to do, kind of plan B, is to break down fats. And the unfortunate byproduct of fat breakdown is ketone production, which leads to acidosis. If somebody goes well beyond this, and I would say is getting quite dire, is if fat breakdown doesn't work, then you have protein breakdown, which its byproduct is lactic acid, which still ultimately leads to metabolic acidosis. So you can understand that the body just really doesn't realize that there's glucose circulating, so it just goes into this perpetual cycle of trying to save itself, but in the end it's actually destroying itself through metabolic acidosis. So treatments is going to be IV fluids to replace any lost fluids, and also potassium replacement. Potassium replacement happens because one, we need to get glucose levels down, so when we start insulin via IV, insulin will also drive potassium into the cells. So we, as nurses, want to not only monitor somebody's glucose levels, but also potassium, and ultimately figure out what the underlying problem is. So just kind of give you an idea before treatment, what's happening is there's kind of like a do-si-do here. With metabolic acidosis, you will have an increase of hydrogen ions, but what also happens is some of the ions will go into the cell and potassium will come out, where you'll have that increase of potassium in the cell. But during treatment, when you're giving a patient insulin, it's pushing both glucose and potassium back into the cells. So that's why you need to monitor both glucose and potassium levels, because you don't know how dramatically that this can dip those. So typically when a patient's glucose levels are getting anywhere below, say, like 200, some references might say 250, but at that point in time you may start to add dextrose to the IV fluids to kind of help keep a person's glucose levels stable, so you don't make them hypoglycemic. In the same token, you'll be monitoring their potassium and doing replacement as needed. So hyperglycemic, hyperosmolar, non-ketotic syndrome, HHNS, you're typically going to see this in elderly individuals with no known history of diabetes or type 2 diabetes. So usually it is related to infection, other stresses, surgery, or dialysis. And unfortunately, when you think of our elderly population, they don't have the same thirst drive, so a lot of times poor fluid intake will kind of compound their symptoms. So it's going to be characterized as hyperosmolarity of greater or equal to 350, and extremely high glucose levels of equal or greater than 600. Symptoms: hypertension, profound dehydration, so know your signs and symptoms of fluid volume deficits. Again, high glucose levels, you'll have some electrolyte levels that are thrown off in BUN that's related to dehydration. And really, students sometimes struggle to understand the difference between the two. The big thing, HHNS, or as Miss Elson, I guess it's also being called short honk in some hospitals, is that it lacks acidosis, serum or urine ketones, and there's no abdominal pain. And the big reason for this is because insulin levels produced are too low to prevent hyperglycemia, resulting in osmotic diuresis, but there's enough insulin being produced to prevent fat breakdown. So that slide where, you know, if the cells aren't getting enough glucose, it'll kind of go to plan B, which is breaking down the fat, so there's no ketones, which doesn't lead to the acidosis. So whereas in DKA, no insulin is present and promotes the breakdown of stored glucose, protein, and fat. The patient population is primarily going to be elderly, again, with no history of diabetes or type 2. Unfortunately, shock or coma is brought upon by dehydration with HHNS or HONC, whereas in DKA is brought on by metabolic acidosis. Treatments are very similar to that of DKA. Big differences with DKA, we wanted typically rapid rehydration, where this patient population is older and can have other comorbidities, say congestive heart failure, so we're going to have gentle rehydration. Correct any electrolyte imbalances, insulin to treat the hyperglycemia, and if there's any other underlying medical conditions, and educate the patient about checking the blood sugar to prevent reoccurrences if needed. So education for patients with diabetes. You need to know foot care, sick day rules, who's at risk for diabetes, and know some of the medication interactions with diabetes. So for example, talked about with some other endocrine disorders, steroids are going to make a person more insulin resistant and is going to increase their glucose levels. So if you have a patient on steroids, you need to tell them to check their glucose more often. Make sure you know all these different points. Like down here, if a patient is doing nail care, it's best after a bath when the toenails are soft and easy to trim. RN shouldn't do. It may need to be done by a podiatrist. Don't remove calluses or corns yourself. Patients should seek a podiatrist. See here, another thing is about keeping feet dry, because again, wet feet can possibly lead to infections. Avoid lotion between the toes. Pat feet dry gently. Again, get between the toes. Test water temperature. Use mild soap. Inspect the feet daily. And here, kind of like when we're talking about hammer toes, you want to separate overlapping toes with cotton or lamb's wool. Avoid open toes, leather shoes over plastic. And, you know, plastic here, like those jelly shoes and Crocs, there's really no absorbency in terms of taking moisture away from the foot. So again, plastic shoes are not preferred. Wear shoes that fit. Wear slippers with soles. That's important because if you're wearing slippers that don't have soles, one, increase for risk, but penetration of objects are easier to go through them. Don't go barefoot. Wear clean, absorbent socks made of cotton or wool that has not been mended. The whole thing about mended is just, again, anything that can cause pressure up against the skin. Don't use hot water bottles. Avoid prolonged sitting, standing, or crossing of legs. That has a lot to do with the vascular impact that diabetes can have, both macro and at the micro level. And clean cuts with warm water and mild soap. Apply a dry dressing, and if healing typically doesn't get better within 24 hours, patients should contact their healthcare provider. Sick day rules. Monitor blood glucose levels 3 to 4 hours. Continue to take insulin or hypoglycemic agents. Even if a patient doesn't feel like eating, they still need to check their glucose levels because of the metabolic demands that illness can cause. It can still elevate their glucose levels, so they may need to increase their insulin, but they should never decrease their insulin when they're sick. And of course, rest is pretty much good for about anybody. What are the risk factors for diabetes 2? Obesity, so BMIs greater than 25. Hypertension are typically things greater than 140 over 90. sedentary lifestyles, hyperlipidemia, cigarette smoking. Kind of like Bob earlier, cigarette smoking really did a number on him. Genetics, your first degree relatives, mom, dad, sister, brother. Certain ethnic groups have an increased risk, and history of gestational diabetes or delivering a baby over 9 pounds. Make sure that you know your risk factors. This is what I talked about earlier, metabolic syndrome. So typically those who might get a diagnosis of metabolic syndrome, they may have some combinations of, say, heart disease, lipid problems, type 2 diabetes, and hypertension. So they don't have to have all these things to have metabolic syndrome, but having several of these can lead to a diagnosis of it. Here's the example that I gave of a type 1 diabetic in illness, and here you can see when they get ill how it does have a direct impact on some of their numbers here, where you can see here they're kind of like in the low 100s, but they really do tend to spike with illness. And this patient here just did not follow their sick day rules. They did not correct. So here, being sick and knowing they were sick, they should have corrected. With this patient being type 1, they weren't on a pump, so they were using a carb ratio, and they should have probably decreased the carb ratio at this time to make adjustments for this. Lifestyle changes for clients with diabetes. So the principles of nutrition. When somebody gets that diagnosis, they think carbs are thrown out the window, but if you look here, carbs are actually play a role, 45 to 65%. When I talk to patients, I really don't talk to them about sugars. I talk about carbohydrates. But you can see here, if somebody ate this entire bag, if they don't know how to read a label, they might say, oh, this has 21 grams of carbs, but if you look up here, the serving is 10, so that is definitely a lot more than 21 grams of carbs, but it is a balance of carbs, proteins, and fats. Fibers, patients who are diabetics can drink alcohol, but too much can increase their risk for DKA. Sweeteners are okay in moderation, and again, watch for misleading food labels. Exercise therapy. So the big thing here is consistent exercise. Again, if you have a patient that is going to go off the rails and decide to do a mud run, which is a little bit outside the norm but is putting more stress, just make sure to educate them about a pre-exercise snack of 15 grams of carbs, a complex carb with at least a protein after exercise, just so they don't get post-exercise hyperglycemia. Try not to exercise while sick. That's pretty much should be rule of thumb for most people outside of diabetics. But again, it's just kind of important for education, same amount, same intensity every day. Again, your body just craves routine. Insulin and diabetes. So typically insulin is usually given sub-Q. Only NPH needs to be agitated. Agitated needs to be gently rolled between the palms. This is the insulin. It is intermittent insulin, and it's usually cloudy. All others insulin should be clear. So when you're doing education with a patient that is taking an insulin that is not NPH, you should tell them, check your insulin every day, make sure it's still clear. If it is cloudy or has crystals in it, it has gone bad, discard it. Rubber cap needs to be clean, and skin should be clean with alcohol or soap. Know your times, know your onsets, your peaks, and your durations. Know your use, know the examples. I want you to know Humalog and Novolog. They're taken before meal for meal coverage. Know your short-acting, your Humulin or Novolin, which is regular, is the only one to be given by IV. Intermittent acting can be used for basal coverage, but your long-acting ones like Lantus, another one which I don't have here, which you don't necessarily need to know, but just for teaching purposes, is Levemir. So when I talk to students about learning the names, I think L for long-acting. Here are the different sites. You always want to tell your patients to rotate their sites and make sure not to give themselves an injection in an area that is bruised, scarred, you know, anything like surgical sites, or if they're having any rashes or anything like that. You basically want the skin to be unbroken as well. This is just a good slide when you're talking to patients about the different locations where they can give themselves an injection. And at least when I talk to my patients, I always try to encourage them to use the abdomen when possible, just because it has the fastest absorption area, especially for those that are taking like a fast-acting or rapid-acting insulin to take with a meal, because you want it to have a fast absorption to address the meal that they're taking at that time. The syringe and needles, syringes usually come in 30, 50, and 100 unit sizes. Needles can be from a 1/2 inch to 3/16 of an inch. Obviously, one's use shorter needle for those who have less tissue. Depending on the patient, 45 or 90-degree angle. If you know, sometimes they pinch, sometimes you don't need to pinch, but that is part of your assessment that you'll do with your patient based on their sub-Q tissue that's available. So the reason why I showed this slide is just to give you a good idea, just outside of insulin, when you're giving your patient an injection, the new needle is, you know, perfectly fine. If you are drawing up a medication with a needle, you can see just from one use puncturing, say, the cap to get to the medication is already starting to dull down a needle. So just be kind of mindful when you're working with patients. If you want to decrease some pain with them, see if you can use a different needle that you'll actually inject them with versus what you drop the medication with. Injection devices, nowadays pens make things very easy. They're already preloaded. A lot of them, like this one for example, has 300 units, easy dial-up doses, and it's convenient. Patients can carry it in their purse or on their belongings a lot easier than having to take syringes, a vial, and needles. Patients with pumps, there's a connection device here, and it is controlled to a pump. It has different settings depending on the patient. You have a basal rate, which kind of is in the background, and then also dosing for meals. Infusion set should be changed every 3 days. Some of the big problems, though, for patients with pumps, and they need to be well educated. They need to be taught about self-monitoring operations, adjusting in response to alarms. Ketoacidosis can normally happen due to inexperience, infections of not changing the site or not changing their infusion set on a regular basis, accidental dislodge of the needle, or pump malfunction. Some of the problems with side effects is local allergy reactions. I see this with some of my patients on long-acting insulin like Lantus and Levemir, and a lot of times it is not a allergic reaction to the insulin itself, but to the preservative that is used with the insulin. Also, some other reactions that can happen to the site is the lipotrophy, which is loss of sub-Q fat. So you see some dimpling. So like in this picture here, you see the dimpling. or lipohypertrophy, where you have a fibrofatty mass at the site, so it's actually raised hardened tissue. So if you have a patient with either of these issues, they should not use those areas for injections. So ways that you can decrease this is by using human insulin, site rotation, and administer the insulin at room temperature. Administering cold temperature stings and puts a person at higher risk for some of these issues here. So insulin therapy side effects, morning hyperglycemia. This has a lot to do because, again, this is all about hormones. So it can just be a response. Say this Semmelweis effect is morning hyperglycemia in response to nighttime hypoglycemia, so the body kind of overcorrects itself. A way to treat it is by having a snack at night. Insulin waning. This can be a rise in blood glucose from bedtime to morning. It can be treated by pre-treating with insulin. The dawn phenomenon, this happens a lot in our type 1 diabetics. And again, it has a lot to do with circadian rhythms and hormones and cortisol changes. So they're usually around 3 o'clock, having elevated blood glucose. And again, it's with growth hormones around dawn. Can be treated by early morning insulin or change of injection of evening intermittent acting insulin from dinner time to bedtime. And also too, if you ever think about it, how cortisol levels are low at night and can rise in the morning based on our sleep cycle, can also have an impact on a person's glucose level. So this last cartoon, I really enjoy these two. It's heart and brain. It says the odds are not in our favor, heart. And heart says that makes it feel even better when we win. So I know these topics are hard. You get a lot of things thrown at you. But, you know, the big thing is try not to study until the last minute. You know, ask questions, understand the whys. When you're looking at questions, you know, think in terms of Maslow's hierarchy. Think of your ABCs. You know, try to apply some of your nursing assessment skills. You have all the tools to answer the questions. Sometimes, unfortunately, I think all of you get lost in your own head, and anxiety can make things hard. But I do believe, though, that when you are successful, that when you feel things are kind of against you, that when you are successful, it just really feels great. So I hope this review is helpful, and I wish you the best in your studies.